Yeah, we'll go to the next slide. Yeah.
So the clinician who saw him was thinking it could be costochondritis or a non-specific viral illness. What would you want to do next?
ECG.
Yeah, exactly. So we were thinking along the same lines. So we had an ECG, some bloods and a chest X-ray. The ECG just showed normal sinus rhythm with a normal QTC. Chest X-ray was unremarkable. There was no consolidation, no collapse, no changes. And his bloods showed a mildly elevated CRP, a slightly low white cell count, but otherwise completely normal. So sort of fitting with a viral illness. Would you want to do anything more next, or would you just discharge? So the furthest he'd been to in the last year was Paris, and no unwell contacts. No TB exposure. So on this presentation, because he was looking so well and his investigations were reassuring, he was discharged with strong safety netting, advised it was likely viral, to come back if the fevers continued.
So this is the second presentation. 10 days later, he presented to the ED again with ongoing daily fever with pruritus. There was no night sweats. There was also a lump noted on the anterior chest wall for about a week. And in further history, there was history of fall onto his chest 4 weeks ago while playing football. What else do you want to know? So as Rebecca said, there was no exposure to TB. There was no weight loss or change in appetite at that point. Yeah, I'm going to describe about the lump. Yes. Any other history do you want? No rash. Examination findings, I'll tell about the examination findings soon. Any other history? Past medical history, nothing significant. Lump, yeah, increasing in size in the last week. Yes. Immunization up to date. So there was a history of fall onto the chest, but there was no visible injuries or break in the skin or fever at that time. So immunization up to date, including BCG. There was no history of contact with tuberculosis or other infectious diseases. He traveled to Paris last summer. No pets, no insect bites. And the past history, nothing significant. Previously fit and well checked. Not on any regular medications. No shortness of breath. No weight loss. Family's history, nothing relevant, like sibling and parents are well. So on examination, he was febrile. There was a firm lump 6 into 6 centimeter over the midsternum. There was no warmth but redness, but it was tender, immobile, and non-fluctuant. There was no palpable lymph nodes. There was no organomegaly, and systemic examination was unremarkable. So what will you do next? Ultrasound? Yes, ultrasound. Yeah, that's what we did. We did an X-ray and an ultrasound. Chest X-ray was unremarkable, and the sternal X-ray showed some. If you look, there is some soft tissue swelling. There is elevation here. So yes, we did bloods as well. Full blood count showed like hemoglobin on the lower side. Again, leukopenic, platelets normal. There was rise in inflammatory markers. CRP 30 and ESR was 65. Ferritin was normal. LDH normal. Blood film showed atypical reactive lymphocytes, Role formation, and normal platelet morphology. There was no evidence of hemoglobinopathy, like HB electrophoresis was normal. Yes, we did other tests, as you said. We did ultrasound as well. This showed small anechoic fluid collection. It was anterior to the manubrium sternum and on the proximal body of the sternum. It was about 1.5 centimeters in size. There was no increased vascularity at the edge. Was it an abscess? That's a good question. But usually, in an abscess, the tumor will have increased vascularity. But this did not have increased vascularity. So what were the differential diagnosis? Yes, malignancy. Yeah, it could be an abscess or malignancy. Yes, so our impression was whether chest wall abscess with underlying possible osteomyelitis. It could be like a pyogenic infection, or it could be tuberculosis, though there was no contact with no history of contact, or it could be malignancy. So treatment, we started on IV antibiotics and ivacaftor and clindamycin. Since he was looking well, he was ambulated. This was a Saturday evening, so we arranged for an MRI on Monday and arranged for a ward review on Monday. So MRI was done a day later, which was, if you can see, there is increased signal in the upper sternum. And it was reported as possible subperiosteal infection with early osteomyelitis in the upper sternum. There was also mild increased signal within the anterior aspect of the upper thoracic bodies, vertebral bodies of uncertain significance. So with this MRI finding suggestive of osteomyelitis, we tried to get input from the orthopedic team, who said they will deal only with long bone infection, not the sternum. And our team was keen to get a biopsy tissue diagnosis, because it's very, very unusual to have osteomyelitis of the sternum. And again, malignancy is very unusual and rare on a sternum. So we wanted to get a tissue diagnosis. So since ortho said they won't get involved, we spoke to our cardiothoracic team, and again we have only adult service here. So with multiple discussions, finally we spoke to the cardiothoracic team at Great Ormond Street. So they kindly reviewed the images, and they thought probably it's an infection, but they also felt it would be good to have a biopsy. So though the patient was ambulated, but in the meantime we were trying to get the biopsy done, arrange date, and there was back and forth conversation with the cardiothoracic team and the ID team for further plan in this child. Yeah, the comment on the vertebral body. This MRI was discussed in the MDT meeting, radiology MDT, and the increased signal in the vertebral bodies was associated with sickle cell, though this child is not a sickler. So few words about osteomyelitis. For osteomyelitis to occur, like the bacteria has to reach the bone. So there are 3 ways by which bacteria enters the bone. The most common route is the bloodstream infection. The hematogenous spread is the most common route of osteomyelitis. And again, it can occur by direct inoculation, as occurs in open fractures, or infection can spread from adjacent site. Majority of pediatric osteomyelitis is due to the hematogenous infection, and acute osteomyelitis is more common in children when compared to adults, mainly because they have increased vascularity of the growing skeleton, especially the long bones, the ends of the long bones is at increased risk because of the increased vascularity to the growth plate here. The nutrient artery enters the bone, and it divides into capillaries and capillaries.
Now I can hear the sound coming out of my phone, but I can't see the screen, so that's not.
Sorry? Okay. So the capillaries take a sharp bend at the metaphysis, and this causes slowing of blood at the metaphysis, which results in seeding of bacteria here. And again, there is low pH at this site, which favors the multiplication of organisms, then inflammation and necrosis. So in children, okay, yeah, and the child is 13 years old. Someone is asking the age of the child. He's a 13-year-old boy. So in smaller children, like especially infants, the epiphysis gets part of the blood supply from the physeal vessels. So the infection can spread from metaphysis to epiphysis and into the joint, and they tend to develop septic arthritis. That's a more common presentation in infants than osteomyelitis. And again, infants have a rich blood supply to the synovium. So similar to this metaphysis, the increased blood supply in the synovium results in increased seeding of the bacteria into the joint. And so septic arthritis is a common presentation of bone and joint infection in infants. So the most common organisms, in 50% of cases, no organisms are isolated. So blood culture has a yield of about 30 to 50%, and culture from bone marrow aspirate gives around a similar yield, maybe slightly better, about 40 to 50%. Of all the positive cultures, Staph aureus is the most common organism isolated in all age groups. In smaller infants, like children, babies less than 2 months, gram-negative organisms and GBS are common. In toddler age group, the most common organism is Shigella kingae. This is emerging as the most common pathogen of osteomyelitis in this age group. We had limited knowledge about this bug like about 2-3 decades ago, and this is a commensal, is a gram-negative anaerobe. It's a normal commensal, oral commensal of little children, and it is known to cause like slow indolent disease with with low-grade symptoms, and inflammatory markers are not that elevated, and it's easy to miss osteomyelitis in this age group. And it was difficult. It used to be difficult to isolate Shigella kingae, but now with better techniques and PCR, we are able to isolate this organism much easily. And it's believed actually all of these culture-negative osteomyelitis in the past could be because of Shigella kingae. Other common organisms are Streptococcus pyogenes and Streptococcus pneumoniae in this age group. And HIV influenza used to be a common organism, but with vaccination, it's not commonly seen. So the other uncommon organisms are Salmonella, as you know, is common in patients with sickle cell disease. And in immunocompromised children, we have to think about tuberculosis and fungi. And Pseudomonas is very specific, like seen in food puncture wounds and in IV drug users. Does the spread to multiple foci suggest Staph aureus? Yes, Staph aureus, especially PVL producing staph, is known to cause like multiple multifocal osteomyelitis, and those osteomyelitis are really severe. They tend to form abscess as well. Okay, risk factors for osteomyelitis. Anyone can, as I said, like osteomyelitis is more common in children because of the increased blood supply to the bones. So anyone with bacteremia can have osteomyelitis, but it's like more children who are more predisposed are immunocompromised children, children with chronic illness who require frequent venesection, which because it creates bacteremia. Children with sickle cell disease, and again because of the microvascular infarcts. Occlusion of the small blood vessels results in infarcts, which acts as a nidus for infection. And again, trauma is an important risk factor. So going to the investigations, leukocytosis is not very common. It's seen in only 1/4 or 1/3 of the patients, but most often ESR and CRP will be elevated in more than 90% of the patients. It's very unlikely to have a normal CRP or ESR in a patient with osteomyelitis. Since CRP has a shorter half-life, it is often used to monitor the progress of the disease. Along with the clinical improvement, there will be fall in CRP with response to treatment. And as I said earlier, like blood culture has a yield of about 30 to 50%. So imaging, can I ask you what's your thought about different imaging techniques which can use for acute osteomyelitis? What do you think about X-ray? X-ray in acute osteomyelitis. Yes, X-ray signs are late. Any guess how long does it take for the X-ray signs to appear? Yeah, it's 7 to 10 days, more than a week, at least 7 to 10 days. So X-ray changes appear late, but it's usually first imaging modality which you we do, this is mainly, it's not to diagnose osteomyelitis, it's mainly to rule out other causes like microfractures and things. MRI is the imaging modality of choice. It has a very good sensitivity of and specificity, more than 90%. It can detect changes quite early, even 3 to 4 days after the onset of infection. So if MRI is not available, CT is another option. Then again, it's not that good for acute osteomyelitis. It can show cortical destruction and periosteal reaction. It's not very helpful in the early stage. Bone scan helpful when we don't know the extent and site of the disease, or in multifocal disease, if you're thinking of multifocal disease. So question here may not show initially, was the fluid collection not vascular on ultrasound? It's because it was scanned early. Yes, possibly, yes. It was 1 week into the infection, but still it was not vascular. I'm not sure. What is the usual time from initial bacteremia to osteomyelitis, or does it depend on the organism? Yeah, it depends on the organism, virulence of the organism, and the immune response of the host. So treatment, going to treatment. So empirical treatment, wide spectrum antibiotics, but definitely the antibiotic should have a good cover for Staph aureus. In small infants or small children, it's good to have a good gram-negative cover, and it is advised to add aminoglycosides, gentamicin or amikacin. So clindamycin is a good antibiotic of choice for MRSA in patients who are penicillin allergic as well. Again, there is wide variation of with regard to the pathogens isolated, as well as the sensitivity pattern, and it's advisable to follow local protocols and to get early input from the microbiologist to guide us on the antibiotics of choice. The duration, traditionally, is difficult. Sorry, I'm looking at the charts as well. It's really difficult. Yeah. Traditionally, osteomyelitis used to be treated with like a prolonged duration of antibiotics, even 6 to 8 weeks of IV antibiotics. But like the recent literature, like recent studies have shown, even short course is as good as the longer course of antibiotics. And most of the studies even say like early switch to enteral route is good, even after the symptoms settle and inflammatory markers are down. You can switch to enteral route, but this applies to uncomplicated simple osteomyelitis. Again, we have to go patient by basis. Like there is no consensus on the duration of antibiotics as such. So sternal tumors. So one of the other differential diagnoses was malignancy. So I thought I'll put a slide on sternal tumors in children. It's extremely rare. It accounts for less than 1% of all thoracic tumors. Again, the tumor can arise from soft tissue underneath the skin, like subcutaneous soft tissue, or it can arise from the bone or cartilage. Malignant tumors usually show signs of destruction on the imaging. And there is a specific entity in children called STELSTOC, self-limiting sternal tumor of childhood. Especially occurs in smaller children. It's a rapidly growing mass. They present with rapidly growing mass without much of systemic symptoms or local symptoms. And they have specific imaging findings like a dumbbell appearance, and usually it improves on its own. So I thought I'll discuss about this a little bit. Seems you see a fair amount of osteomyelitis in children. What do you think? Just because? Yeah, as I told earlier, like the bone and joint infection is common in children. So I'm just answering to the chat question from Christine. Because of the increased vascularity of the growing skeleton, any bacteremia, there is increased risk of bone and joint infection in children. Okay.
So 5 days after he was ambulated on antibiotics, the patient's mum was contacted. So every day in between after he was ambulated, mum was spoke to every day on the phone or via email to get an update on how he was doing. And obviously, as everyone knows in the background, we're also trying to liaise with all the other teams who are involved in his care to try and organise a biopsy and get a more definitive diagnosis as to the cause of the osteomyelitis. So we were speaking to GOS and to our radiologists here to try and arrange a biopsy. So 5 days after he was ambulated, he was continuing to spike high fevers daily, and his sternal swelling was the same as it was before. It hadn't started to go down yet. He had repeat bloods done. HB had dropped slightly, but still wasn't particularly low. It's 102. His white cells were normal, neutrophils normal. The rest of his full blood count was unremarkable, and his CRP was 25, and the ESR I think was 50. So nothing had really changed much from starting the antibiotics. So what do you think is going on? So all his cultures have been negative so far.
Yeah, resistant organism.
Yeah, so it could be a resistant organism causing the infection. And yeah, poor penetrance. Sure, could need draining. Fine, so the differentials for infection not responding would be a resistant organism, an uncommon microbe that we weren't covering with the antibiotics, an unusual host, so something underlying such as an immunodeficiency or malignancy, which was on our list of differentials all along. So after liaising a lot with the cardiothoracic team at GOS, there was going to be a long wait for a biopsy. So we spoke to our interventional radiology team locally and an ultrasound guided biopsy. They weren't confident to biopsy the bone here without cardiothoracics because of the risk that it could be porous or fragile from the infection. So we just did a tissue biopsy. On the microbiology, there were no pus cells or organisms seen. There was no fungi isolated. We did a 16S DNA PCR to look for bacteria, which was negative, and then acid-fast bacilli stain, which was negative, and a culture was negative. And the histology just showed features of chronic inflammation with chronic inflammatory cell infiltrate. He had special stains for bacteria, AFB, and fungi, which were all negative, and there was no granuloma formation or evidence of malignancy, and a CD1 stain was negative as well. So the other tests that he'd have up to this point was he'd had multiple blood cultures, all of which had been negative, urine culture, which was negative, a urine pneumococcal antigen test, which was negative, 1,2 and quantiferon tests, which were negative, an ASO, which was positive, but we weren't sure of the significance, and EBV IgM, which was negative. Yeah. Sorry, so as Mike Smith said in the chat, the biopsy was of the pre-sternal swelling, not the bone. So we also did an immunodeficiency workup, as we were wondering why he wasn't responding particularly well to the antibiotics. His IgG was ever so slightly raised, but IgA and IgM normal. C3 and C4 ever so slightly raised. Vaccine responses were normal, and he had his T lymphocyte subsets examined, and they were all normal, and his HIV was negative.
Brucella, we didn't specifically look for Brucella. There was like a question about Brucella in the chat. I don't think
so he had a film, so he had repeat blood counts which were being done regularly. His white cells had dropped slightly, but the rest of his blood count was pretty stable. His ESR had come down from 50 to 25, and his CRP had also come down. He'd stopped having fevers and rigors. The lump over his sternum was much flatter. It was no longer tender, and he'd been afebrile. And the blood film just showed neutropenia. So by this point, with the biopsy, all the blood investigations and the cultures and everything that we'd done, we'd come to the diagnosis of a primary sternal osteomyelitis, but in the background, we're still working to make sure that we were liaising with cardiothoracics and
IDT.
and also infectious diseases, Evelina. So primary sternal osteomyelitis in itself is a really rare diagnosis to make, especially in children. It's of a hematogenous spread, like other osteomyelitis. The majority are secondary. This is mainly in adults, so like following sternotomy, subclavian line insertions, IV drug users, and also from, sometimes it can occur from chest compressions done in CPR. And it usually occurs in immunocompromised patients. It's really rare without any predisposing factors, and it's difficult to diagnose, as you can see from all that went on with our patients. And I think in pediatric patients, it's about 1 to 2% of all osteomyelitis are sternal osteomyelitis.
Genetics.
So we didn't do any genetics. There was no family history.
At this point, we didn't investigate for autoimmune condition, but like the differentials were mainly any tumors or like there was like infection, because his inflammatory markers were raised, but we in the literature search we couldn't find any autoinflammatory condition which would present this way. I'm answering to Sam. Yeah, it could be Mycobacterium tuberculosis. Yes, that's why we send the specimens for like AFP stain and Mycobacterium PCR as well, which were negative. They have a picture of the histology slide. We don't have. We don't have in our presentation. But there was no granulation tissue. It was just chronic inflammation.
So the patient had a repeat MRI of the whole spine, just done because of the previous one showing that increased signaling in the upper thoracic vertebral bodies. There was no spinal abnormality seen, but an abnormal soft tissue lesion within the mid-thoracic paraspinal region and some posterior mediastinal lymph nodes, possibly related to the sternal osteomyelitis. And the MRI report said that lymphoma probably needs exclusion. So we went on to do further investigations. He had a pelvic ultrasound and abdominal ultrasound, which were normal. A CT thorax, which again showed this soft tissue mass, and the report said that it was consistent with necrotic lymph nodes. He continued to have repeat bloods to monitor his response to the antibiotics, and his full blood count remained pretty stable. He also had AFP and beta-HCG sent, which were normal, and hematinics, which were normal at that point. His CRP had come down further still to 1, and his blood film again just showed a neutropenia, but with normal morphology and reactive lymphocytes. And at this stage, he had immunophenotyping, and there were no abnormal cells seen on the immunophenotyping. So we continued on the IV antibiotics to give a prolonged course for the sternal osteomyelitis. On the 22nd of January, he'd completed 7 weeks of IV ceftriaxone and oral clindamycin. We'd come up with this course based on discussions with infectious diseases at Evelina, talking to the team at GOS and also with our microbiology team. We did a repeat MRI after completing the antibiotics, and it showed significant improvement in the body of the sternum and the surrounding soft tissues. It showed that this posterior mediastinal soft tissue mass, which we'd seen before, was still there, but it had not increased in volume. The report of the MRI stated that the appearances were of uncertain significance, but TB remained a possibility and malignancy less likely. Is there any So 4 weeks later, the patient was admitted to GOS under the cardiothoracics team to have a biopsy of this posterior mediastinal mass of the lymph nodes. He had an echocardiogram at that point, which showed a structurally normal heart with no vegetations. And from the biopsy, he had tissue sent for gram stain, PCR, 16S and 18S DNA PCR, fungal cultures, AFB and a immune stain, and histopathology. So All of these results were normal, so the cultures were all negative, fungal culture negative, no AFB seen on the stains, and the histopathology just showed reactive lymph nodes. He was kept in for a couple of days in GOS after the biopsy, just for pain relief, and I believe he spiked 1 fever. He had normal bloods at this stage and negative blood cultures, so he was discharged home with safety net advice. And so we'll await the results of the microbiology and histopathology.
He had a chest drain as well for 24 hours, which was removed and then discharged after a day from GOSH. So basically, to recap, this is a 13-year-old who presented with fever and sternal lump, and which was like tender sternal lump, and imaging was suggestive, like inflammatory markers were high, imaging was suggestive of early osteomyelitis, treated with IV antibiotics for 7 weeks, and into 2 weeks into 2 weeks of antibiotics, he became afebrile. So symptoms that inflammatory markers normal, and repeat imaging was normal. The sternum was completely normal in the repeat imaging, but there was an incidental pickup of posterior mediastinal nodes, which was when we had a tissue biopsy, like excision biopsy of the node, which showed chronic inflammation or reactive nodes. So symptoms settled, and all the imaging as well as histopathology so far had been normal. He was investigated for tuberculosis as well, but quantiferon was negative, and AFB stain was negative, culture was negative, PCR was negative in the specimen from the sternum as well as from the posterior mediastinal lymph node. So symptoms settled, he was fine for about a couple of months, at least 6 weeks, 7 weeks, but he presented a week after the biopsy to us with the symptoms of fever since discharge from Great Ormond Street. So there are a lot of questions coming up.
Sorry, so this is 16S and 18S DNA PCRs are to look for bacterial and fungal DNA. So the 16S is for eukaryotes and the 18S is for prokaryotes. And it just looks for, particularly if you've already started treatment with antibiotics before you can take the samples for cultures, it looks for any bacterial DNA that might not have been picked up on cultures, so it's more likely to give you a diagnosis.
It's a PCR, so it's very sensitive. Even after starting antibiotics, it can pick up. So 1 week symptoms settle, and then 1 week after the biopsy, comes back with temperatures up to 40 degrees, rigors and chills. So no other localizing symptoms, and investigations. Bloods show like bloods, except for this leukopenia, it was just unremarkable, and the FBC and ESR, CRP normal. There was some elevation of AST, and LDH was elevated this time. Again, blood culture was sent and urine culture was sent, and this he enters a COVID era now. And then he had this COVID swab, which was negative as well. All the investigations were done in the ED, and he looked otherwise well except for the temperature. He was sent home on azithromycin, and he became afebrile, and it was continued for another 7 days. So at that point was like whether it's a COVID or it could be like post-op fever or like any respiratory with secondary chest infection. So again, but symptoms settled, but again he came back 2 weeks later with recurrence of fever, reduced appetite and weight loss. Examination was unremarkable. There was no palpable lymph nodes, no liver or spleen enlargement. He was admitted this time, and investigations was sent, and he was observed. He continued to have fever spikes, at least 2 spikes in a day, like around 39 degrees Celsius. So it was discussed with all the ID team and microbiologists, and IV ceftriaxone was started because last time, the previous admission, he did respond to IV ceftriaxone. So bloods again, leukopenia persisted, hemoglobin on the lower side, and the blood film showed atypical reactive lymphocytes. ESR was normal, and CRP was normal, and there was elevation of liver enzymes. Ferritin was increased, LDH was elevated, triglycerides elevated, and there was history of myalgia, so CK was sent, and CK was elevated as well. There were multiple blood cultures. I think I'm not able to follow the questions here at the same time. So there were multiple blood cultures which were sent during this admission as well, which were all negative. Is this MAS? Yes. Yes, HLH. There's a question from Sam. Is this MAS? Yes, possible. That was one of our differentials. So what are the possibilities? As you said, like one of the possibilities is HLH. What are the things what are the other differentials? Myocytoma. TB still, yes, TB still a possibility. A new infection. Autoinflammatory. Some autoimmune conditions, yes. Okay, so you are considering whether it's any malignancy, which is still not diagnosed, or HLH, some autoimmune or connective tissue disorder, or there is CRMO, chronic recurrent multifocal osteomyelitis. So a few words about HLH. HLH is, do you want to do bone marrow biopsy? Yes, in this admission we did bone marrow as well. So HLH is an abnormal immune activation resulting in excessive inflammation and destruction. There are two types of HLH, familial, new. Yes, we did consider malignancy as well. Familial HLH, it's mainly it's due to genetic defect and usually manifests quite early during infancy. So the child presents with fever and has like multi-system inflammatory response, like present basically as sepsis with SIRS and not responding to antibiotics, then we should consider familial HLH. And the second HLH occurs secondary to any inflammatory process. It could be secondary to infection or autoimmune connective tissue disease or after malignancy. So this autoimmune, the rheumatologists call this HLH as MAS. So if it occurs after secondary to a rheumatological disease like SLE or JIA, then usually they use the term MAS, which is macrophage activation syndrome. Someone mentioned this MAS. So HLH is a possibility in this child. So it's basically febrile, they present with a febrile illness with multiple organ involvement. So this is the diagnostic criteria. 5 out of 8 criteria is usually positive to make a diagnosis. Fever, splenomegaly, cytopenias, hypertriglyceridemia, or hypofibrinogenemia. Increased ferritin, sometimes the ferritin is like in thousands, like 5,000, 10,000, but at least it should be more than 500. Elevated soluble CD25 and low or absent NK cell activity, and hemophagocytosis, which can be demonstrated in any reticuloendothelial tissue. Mostly we do bone marrow to demonstrate hemophagocytosis. So the other supportive things are like elevated transaminases, which this child had, elevated LDH and elevated D-dimer. So he had few things which fit in, like fever, cytopenias, triglycerides slightly elevated, ferritin was elevated. So this was one of our differentials. So something about CRMO, it's chronic recurrent multifocal osteomyelitis. It's an idiopathic inflammatory condition which presents similar to osteomyelitis, but without any features of infection. So they present with pain, swelling, and sometimes mostly with pain and swelling, and sometimes with systemic symptoms like fever. It is confined to only one bone. It's called chronic non-bacterial osteomyelitis. It could be focal or unifocal or multifocal. So it's a self-limited disease. 50% have chronic persistent course, and about 20% have chronic recurring course. It's a diagnosis of exclusion. We have to exclude infection and before we label any CRMO. The treatment is NSAIDs, and if they don't respond to NSAIDs, they are managed by rheumatologists. They give steroids and DMARDs. So going back to our patient, so this time we had like again further investigations because he was presented with fever again. He had all this infective workup. Blood culture was negative, multiple times sent. Urine culture was negative. Again, viral CME, EBV, PCR negative. COVID, 2 swabs negative. NPA negative. ASO was positive. BDG is like a fungal serology which was negative. So he had autoimmune workup. So all the autoimmune workup were negative. Whole body MRI was done, so which showed like improved appearance of the sternum and the posterior mediastinum, no features of CRMO, new enlarged para-aortic, paracaval, and iliac lymph nodes. There were also focal enhancing lesions, one in the bone marrow, in the posterior acetabulum, and there were 2 lesions, one subcutaneously in the anterior abdominal wall and one in the muscle, gluteus medius muscle. So with this lymph node and subcutaneous swellings, there was possibility of LCH with this. After this imaging, the other possibility considered was LCH. So few words about Langerhans cell histiocytosis. It can either present as a unifocal disease with single osteolytic bone lesion, which is called as eosinophilic granuloma, or it could be chronic, present as chronic. It presents in 3 forms. One is chronic unifocal form or chronic multifocal disease. Again, it's a bone lytic bone disease. Depending on the site of presentation, symptoms vary, but the classic triad is bone lesions, lytic bone lesions, diabetes insipidus, and exophthalmos. And the third presentation is systemic disease, which is acute disseminated LCH. They present with fever, cytopenias, lymphadenopathy, liver spleen enlargement, skin lesions, which can be papules or dermatitis, subcutaneous nodules, which this boy had, and lung and CNS involvement. So this time we arranged for, like, under one GA, we arranged for multiple procedures. He had a bone marrow trephine biopsy, muscle biopsy, and soft biopsy of the nodule in the abdominal wall. So bone marrow biopsy was normal, no blast, no evidence of HLH or lymphoproliferative disorder. Bone marrow culture was negative. Muscle biopsy, overexpression of class 1 HLA, and soft tissue biopsy. Like he had anaplastic large cell lymphoma, which was positive for ALK, which is ALK is a marker like anaplastic lymphoma kinase. I think, yeah, ALK was positive. So finally, it was malignancy. So final diagnosis, anaplastic large cell lymphoma. The boy and the family were counseled and they were referred to Royal Marsden for further management.
So just a few words about anaplastic lymphoma. It accounts for 10 to 15% of all non-Hodgkin's lymphoma in children. The mean age of presentation is around 12 years of age, and it affects boys much more heavily than girls with 6.5 to 1 ratio. The presenting features are sort of those of malignancy generally, so lymphadenopathy, fever, weight loss, night sweats, and they can present with an unusual course of like waxing, waning lymphadenopathy, and the prognosis just depends on the staging.
It's quite rare, like even in a tertiary like pediatric oncology center, they see about 1 to 2 new cases per year, and it has this peculiar presentation sometimes like waxing and waning lymphadenopathy and systemic symptoms, which makes the diagnosis really difficult.
So bone involvement in lymphoma, it can be nodal, so you can get lymph nodes, spleen or bone marrow involvement. 1/3 of all non-Hodgkin's lymphoma is extranodal, so affecting the gut, testes, CNS bone, thyroid, salivary glands. And primary bone lymphoma is less than 1% of all lymphoma. And you can get bone disease presenting in the later stages. So just a few interesting papers that we found whilst researching this case, where lymphoma can present as an osteomyelitis. There's I think they were mainly American cases. One was an adult, but he had kept presenting with an osteomyelitis of his right shoulder, but with negative cultures, and interestingly, kept presenting having pus, washouts, etc., and then eventually was diagnosed as a Hodgkin lymphoma. And there's another patient who presented as an osteomyelitis vertebra. Had a similar case in that they're suspecting a malignancy from the beginning, and did lymph node bone marrow biopsies, and the bone marrow was negative as it was in this case, but the lymph node biopsy was positive for the lymphoma.
So there were few case reports. There were few case reports both in children and adults, mostly in adults. and a small case series as well, which I've seen, like where lymphoma, like mimicking osteomyelitis. So this patient, he had like involvement from multiple specialties, ID, microbiology, pathology, hemato-oncology, both in his first admission and the second presentation as well. It was we were continuously liaising with different teams in our hospital as well as at Gosh, and it was really difficult, like to coordinate and things. But finally, we had the diagnosis in the second admission. So, some few words about PUO. Though actually PUO, the first time around when he presented, it was not really PUO. He had a focus. He had like yeah, just a lump on the chest. So our investigations and approach was completely different. But the second time he had like a post-operative, he came with fever. He was COVID season as well, and then the first 2 weeks, okay, because of that. But later, yeah, we had to go like a PUO child. So there is no consensus on definition of pediatric PUO. In adult, there is a different definition of 1 week and 3 week investigations. Here, pediatrics like fever lasting for more than a week with no apparent diagnosis, with thorough evaluation, the history, examination, and investigations. It's just considered as PUO. So it needs a systematic evaluation with detailed history and examination, good diagnostic, basic diagnostic tests, and later the tests are targeted to the findings. So in one fourth of the most of the times with febrile illness, what happens is the febrile illness like settles without we arrive at a diagnosis, or the disease manifests itself with new symptoms coming up, which helps us in making a diagnosis. So in 50% of the patients, if we evaluate them, they have infection, and about like 10% is due to rheumatologic illness and 6% is due to neoplasm. So this is the general big category. One is like infection. So when any patient presents with fever for a long duration, more than a week, the infection we should look for any local infection. Generally, we'll do like screen for all systemic infections like tuberculosis, HIV, EBV, CMV, and things. But things like sinusitis, we have to look for sinusitis, mastitis, endocarditis, and abscesses. We have to do ultrasound for abscess, intra-abdominal abscess, bone and joint infection. So infection, this is because 50% of these children do have infection. So inflammation, which could be autoimmune and connective tissue disorder. Again, the common things are SLE, JIA, and JIA. Malignancy, again, lymphomas, leukemias can present just as fever, or sometimes soft tissue sarcomas and other malignancies. And the miscellaneous group, where we have like a drug fever, or sometimes it's factitious illness. So we have to admit the patient and drug the fever and look at the fever chart, or other diagnoses like some endocrine things like thyrotoxicosis and things can present with prolonged fever. So it's just broad category. I won't go into discussion about PUO. So some take-home messages. So use a systematic approach in investigation. Reassess when symptoms persist or symptoms are unusual. Discuss with colleagues and relevant subspecialties, and be persistent. So any other questions about this case, or any other questions? How come it wasn't picked up in the biopsies at Gosh? Copy of the slides. You can email slides. First time biopsy, non-specific inflammation. Okay, if there are no other questions, we can end the session. Thank you. Anything else you want to say? Thank you.